Prognostic factors in small intestine nets. What determines your survival? Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with a small intestine neuroendocrine tumor, you're probably wondering what determines outcomes. I know hearing terms like Ki-67 or mesenteric mass feels overwhelming, but today we're breaking down which factors influence survival and what this means for treatment. Small intestine neuroendocrine tumors arise from hormone-producing cells in the small bowel. Most are slow-growing, well-differentiated tumors. According to 2024 European guidelines, they are graded as G1 when Ki-67 proliferation index is under 3%, G2 when it is 3 to 20%, and G3 when exceeding 20%. Understanding these grades matters because they directly impact your prognosis. Ki-67 is the single most important prognostic factor. Now, what does this look like in real terms? It's a protein marker showing what percentage of tumor cells are actively dividing. Think of it as a speedometer for cancer growth. Research shows Ki-67 greater than 10% predicts a poorer prognosis. A G2 tumor with Ki-67 of 5% behaves very differently from one at 18%. You can do the math, right? That's more than 3 times the proliferation rate. Well-differentiated G3 tumors, Ki-67 20 to 50%, fall between standard nets and aggressive carcinomas in survival. If you're supporting someone through this, ask for the specific Ki-67 number, not just the grade. The mesentery holds intestines in place and contains blood vessels and lymph nodes. SI nets frequently spread here, creating masses that can encase vessels, cause obstruction, and trigger carcinoid syndrome. Complete resection of primary tumor and mesenteric nodes achieves cure in 80% of cases at specialized centers. But here's the critical part. Success depends on the Orval classification of vessel involvement. Stage 0-2 is generally resectable. Stage 3, with extensive superior mesenteric artery involvement, is difficult. Surgical clearance relieves symptoms and improves outcomes, but only when performed by experienced surgeons using vessel-sparing lymphadenectomy. This technique halves the amount of bowel removed compared to traditional approaches. The number of liver metastases, not just presence, influences outcomes. Liver involvement greater than 30% indicates high tumor burden and warrants more frequent monitoring every 3 to 6 months versus 6 to 12 months for lower burden disease. Multiple metastases influence whether you are a candidate for aggressive surgery versus systemic therapy. Small metastases under 1 centimeter appear as low echogenic lesions on imaging. Large ones over 1 centimeter show characteristic halos and may have central necrosis. Interestingly, primary tumor size predicts less than Ki-67 or nodal involvement. That said, tumors over 2 centimeters have higher lymph node involvement rates, and you need at least 8 lymph nodes examined for proper staging. We're not talking extremes here. A 1 centimeter tumor with extensive nodes can be more aggressive than a 3 centimeters tumor without spread. This is why manual palpation during surgery is crucial. 40 to 60% of patients have multiple synchronous tumors not detected by preoperative imaging. Chromogranin A released by neuroendocrine cells predicts progression when levels exceed 10 times normal. But here's the complication. Proton pump inhibitors, heartburn medications falsely elevate it, as does kidney disease. Discuss with your doctor. Are medications affecting results? Is kidney function normal? Most importantly, are levels trending up or down? R0 resection, complete removal with clear margins, significantly impacts outcomes. There is no evidence supporting adjuvant therapy after complete resection, making R0 at first operation critically important. The surgical gold standard includes an open approach with manual palpation of the entire small intestine and vessel-sparing lymphadenectomy, limiting bowel resection. Ask your surgeon, what is your SI net experience? How many procedures do you perform yearly? Do you perform vessel-sparing lymphadenectomy? Well-differentiated G3 nets Ki-67 20 to 50% show regular vessel networks and organoid patterns without geographic necrosis. These behave differently from poorly differentiated carcinomas, with longer survival than carcinomas but shorter than G1 and G2 nets. This distinction affects treatment. G3 nets may respond to peptide receptor radionuclide therapy, while carcinomas require platinum chemotherapy. Your pathology report must specify Ki-67 index and differentiation status. Get your complete pathology request-specific Ki-67 percentage and differentiation status. This information is foundational for all decisions. Seek specialized care. The 2024 guidance emphasizes referral to ENETS centers of excellence. Specialized centers achieve 80% complete resection versus potentially lower rates elsewhere. Understand your imaging. Ask how many liver lesions exist and mesenteric mass locations are relative to major vessels. This determines resectability. Resectability. What's my Orval stage? Am I a candidate for vessel-sparing lymphadenectomy? Understanding stage 0 irresectable versus 3 difficult sets, realistic expectations. Biomarker monitoring. Should we track chromogranin A? Could my proton pump inhibitor affect results? What level indicates progression? Follow-up intensity. Given my Ki-67 tumor burden and resection status, how often should I have imaging? Intervals should be tailored every 3 to 6 months for residual disease versus 6 to 12 months after curative resection. Multivariate risk, considering all factors together. Ki-67, mesenteric involvement, liver metastases. Where do I fall on the risk spectrum? Rising chromogranin A levels, increasing over 25% from baseline, suggest progression and warrant repeat imaging. New symptoms. Flushing, diarrhea, or carcinoid syndrome occurring in 20 to 30% with liver metastases requires echocardiography to evaluate for carcinoid heart disease. Rapid tumor progression within months suggests aggressive biology and warrants treatment changes or second opinions. Mesenteric complications, obstruction, or severe pain could indicate mesenteric disease progression requiring urgent specialized evaluation. Prognosis depends primarily on Ki-67 and mesenteric disease extent, with liver metastases and resection completeness also crucial. Your next step is to obtain complete pathology with a specific Ki-67 value and seek evaluation at a specialized multidisciplinary NET center. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here that you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.